Tēnā koutou, ko Stephanie Tokuinga. I'm Stephanie, or just Steph. So if you attended the Campus Colloquium last year, I did present some of this work previously, so these are just some updated results as well, and as Barry said, looking at health outcomes specific to first-class rugby players that have been linked to the integrated data infrastructure. So you probably see this a bit today, of course, the disclaimer. I'm not going to read it out. Okay, so to provide some initial background for this study, I'm sure that you've seen in the media, there have been increasing concerns over the risk of participating in contact and collision sports, and this particular attention in recent years been directed towards rugby union. And these concerns have largely been driven by the relatively high incidence of head trauma, so concussions and repetitive head impacts in contact and collision sports. The significance of this issue is highlighted by the identification of traumatic brain injuries, as you can see up there, as one of 14 modifiable risk factors by the Lancet Standing Commission, as well as the discovery and autopsy of chronic traumatic encephalopathy in the brains of former athletes, and it's a neuropathology that's been linked to repetitive head impacts. So the clinical significance of this neuropathology has yet to be kind of fully understood. So as a result of this kind of attention, much of the research on contact sports has focused on neurodegenerative disease, such as Alzheimer's disease or dementia more broadly. Few studies have been able to investigate some of the kind of rarer neurodegenerative diseases like motor neuron disease, because it's quite challenging to obtain large enough case numbers in this instance. And recent systematic reviews and meta-analyses that have been conducted, so some of those that have been cited up there, have indicated, though, an increased risk of neurodegenerative disease and mortality attributable to neurodegenerative disease, particularly in professional level contact sport athletes. So higher mortality from this has been reported in professional association football, so soccer, as well as American football athletes when compared to the general population. However, of course, it's also important to acknowledge that there may be health-related benefits associated with participation in physical activity, and so first-class level sports. So we may also see some positive outcomes linked to participation in first-class contact and collision sports. So a meta-analysis by Runacrest and colleagues on studies of former elite-level athletes, not just exclusively contact sport athletes, have reported increased longevity and a reduced incidence of death due to cardiovascular disease and cancer relative to the general population. And studies that have reported an increased risk of death related to neurodegenerative diseases have also found lower all-cause mortality in contact sport players relative to the general population. So these studies seem to suggest that while contact sport athletes may have an increased risk of neurodegenerative disease mortality, the participation in the sport may also protect against all-cause mortality and some other chronic physical health conditions, such as cardiovascular disease and cancer. So kind of a bit of, some not great outcomes and then some positive outcomes. So to date, most of the large-scale longitudinal studies that have been conducted in this space have focused on outcomes for association football, so soccer or American football players. In comparison, there's very little evidence in rugby union, and this is actually concerning because rugby union actually has a relatively high incidence of concussion when compared to other contact sports. But at the moment, there is only a single longitudinal study published using administrative health records to investigate health outcomes in rugby players. So this study was conducted by Russell and colleagues. They looked at mortality outcomes in former elite Scottish international players, and they found that players had 2.7 times the rate of neurodegenerative disease compared to the general population. However, The study had a relatively smaller player cohort, so about 400 players, and this resulted in low counts of neurodegenerative disease outcomes. So this does reduce their statistical power and can limit the precision of the estimates, particularly when you're getting to those smaller neurodegenerative diseases. And then we're looking at some player-specific risk factors. Research from American football and soccer have suggested that there may be evidence of a dose-response relationship between participation in contact sport and neurodegenerative disease risk. So some studies have shown that longer career duration or playing at, say, a more professional level may increase the risk of neurodegenerative disease outcomes amongst players. But this does seem to be mixed within the literature. It's not consistently observed. And then current evidence is unclear regarding the association between player position and the risk of neurodegenerative disease. So in soccer, an increased risk has been shown for playing positions that are typically associated with a greater number of head impacts, so hitting the ball. But then the study of rugby players, Scottish rugby players by Russell and colleagues, showed no difference by player position. So with rugby, playing positions can broadly be grouped into forwards and backs. So forwards are typically larger players. They're charged with gaining possession of the ball, typically involved in more tackle events, whereas backs tend to be smaller and faster and tasked with gaining field possession. So what research looking at sort of the type of contact events and injuries in rugby have shown is that players in forward positions are generally more exposed to contact events than the backline players. But, and this has been found in studies that are looked at I don't know if you've seen like the instrumented mouth guard that have come out recently. But when you're looking at injuries, what you do see is that there's evidence that backline players tend to have a greater risk of injury, including head injuries when they're exposed to contact events. So there's sort of this unclear relationship here where you've got forwards exposed to more contact events, but then the backs seem to perhaps be getting injured more. So based on the sort of general lack of research in this space, particularly for rugby union players, this motivated the development of the Kumanu Tāngata study. So this, as Barry mentioned, is a collaboration with us here at Compass and New Zealand Rugby. The name was gifted by the New Zealand Rugby co-matua Lou Crawford and tries to get this sort of double meaning of working with this data to sort of care for the well-being of the players. And it translates loosely to the idea for the aftermatch. So with this study, we utilized the integrated data infrastructure, of course, to try to look at a wider range of health outcomes and have a considerably larger sample size than what's been done before. So I don't need to go into the idea. I've already had that kind of mentioned to you, but essentially what New Zealand Rugby were able to do, as Barry mentioned before, were link the rugby register to the IDI. So this register was compiled by a New Zealand Rugby historian, Clive Akers, and they linked it to the IDI spine. We kind of just got the key information around sex, birth year, and then some player-specific variables, which I'll mention shortly. And about 16,000 records were provided to Stats New Zealand for linkage, and about 13,800 were successfully linked, but we followed some exclusion criteria to kind of account for data availability, the age of players, and potential linkage errors. And this reduced our sample size to just under 13,000, 12,800, roughly, players born between 1920 to 1984. And we compared them to general population males who were born within the same birth years. So in green, you've got the distribution of players, and black is the general population males. And then we applied direct standardization essentially to try to match the distributions for the general population so that we could account for differences between the general population and the players in terms of their demographics. So you can see I've got the distributions up here for ethnicity and then New Zealand born status, and we also did it for birth year bands. But essentially, after weighting, you can see that the distribution of the general population matches that of the players. And then our outcomes of interest, we do look at, we're interested in a range of outcomes, but today I'll focus on neurodegenerative disease diagnosis. Sorry, that text is very small. But that is looking at any neurodegenerative disease, Alzheimer's disease, other dementias, Parkinson's, and motor neuron disease. And then I'll also talk about mortality. So this was all-cause mortality, which was from 1950 onwards. And then cause-specific is only from 1988 onwards, just because the mortality, that's when the mortality records are available from. And that was neurodegenerative diseases, cardiovascular disease, cancer, suicide, alcohol, substance abuse, metabolic, respiratory, digestive, and then other or identified. And so this was obviously mortality records, neurodegenerative disease diagnoses, so just morbidity came from both hospitalization and mortality records using clinical codes. And then our player-specific variables included exposure to the sport, playing level, and position played. So exposure to the sport was measured using the number of years an individual played first-class rugby and the number of games they played and categorized into tertiles. And playing level was based on whether the individual was categorized as international professional or provincial first-class amateur. So the international professional category included those who represented the All Blacks since the 1950s and those who played in the New Zealand professional Super Rugby competition since 1996, when the sport was professionalised. And then the other category, the provincial amateur category, included players representing one of the 27 provincial rugby teams since 1950. And then playing position was categorised as forwards or backs. And then to examine the risks of neurodegenerative disease morbidity and all-cause and cause-specific mortality between players in the general population, and evaluate the risk for the player-specific variables as well. Our primary analyses involve running Cox proportional hazards models to look at hazard ratios, basically looking at what the risk was for players compared to comparative groups. Right, so our mean follow-up period, so from age 30 for the people in the study until they had a diagnosis of a neurodegenerative disease or censored, so either they passed away, left the country, or the study period ended, was about 37 years. And over this time, 6.5% of players and 5.2% of the general population were identified as having any neurodegenerative disease. And then compared to the general population, what this tells us essentially is that players were more likely to be diagnosed with any neurodegenerative diseases, and then specifically Alzheimer's and other dementias. And then further, so what that plot tells us as well is it's essentially plotting the risk at different age bands. And it tells us that for any neurodegenerative disease and other dementias in particular, this increased risk appears to begin specifically around 70 to 80 years of age, so not prior really to this age. But we don't see this sort of age, this differential risk by age for Alzheimer's disease. And then when we look at player position, so compared to the text is quite small, apologies for that. Compared to the general population, there was an increased risk of any neurodegenerative disease, Alzheimer's and other dementias for the backline players compared to the general population. And there was also a reduced risk of Alzheimer's disease and other dementias for forwards compared to backs. So they had less risk of these outcomes, but there was no increased risk of neurodegenerative disease diagnosis for the forwards compared to the general population. And then when looking at it by player level, compared to the general population, we see an increased risk of any neurodegenerative disease, Alzheimer's, and other dementias for both those who played at the amateur provincial level and the international professional level. And there was also an increased risk observed for any neurodegenerative disease and other dementias for the international professional players compared to the provincial and amateur players. And then when we look at exposure, greater exposure did seem to be linked to an increased disease risk, although not necessarily in a dose-response way. So for years played, an increased risk was associated with any neurodegenerative disease, Alzheimer's, and other dementias when compared to the general population. And the greatest estimate was observed for those who were active for 6 or more years. And then for matches played, an increased risk was associated with any neurodegenerative disease, Alzheimer's, and other dementias when compared to the general population for those who played over 5 matches. So those were our neurodegenerative disease morbidity outcomes. I'll switch over to talking about the mortality outcomes. And what this shows here is that when looking at all-cause mortality, so any cause of death, there was a protective effect of participating in high-level rugby prior to age 70. So this protective effect does seem to reduce with age. And then when we look at cause-specific mortality, we see a somewhat different results depending on the cause. Very small, slightly protective effect against cancer in middle age. A protective effect for respiratory disease mortality. So this will be things like COPD, asthma, and metabolic conditions, so say diabetes, as well as other unknown, though again, the effects do seem to vary across age. And then when looking at it by player position, what this shows us is that the differences, again, seem to depend on cause of death. Both playing positions were more at risk of mortality due to neurodegenerative disease. Backs were less likely to die from most cause-specific mortality outcomes otherwise relative to the general population. Forwards had a greater risk of all-cause cardiovascular disease, metabolic, and other or unknown mortality relative to the backs, maybe because they're larger bills, not sure, but protected against alcohol and substance use disease-related death, though the confidence intervals do start to get a bit wide for this just because of the smaller numbers. And then when looking at mortality by player level, what we see, we do start to get a bit, as you can see here, some numbers, issues with small numbers. But what we see again is an increased risk of neurodegenerative disease mortality and a reduced risk of respiratory mortality for the provincial, amateur, well, regardless of player level, but this is compared to the general population. And then when we look at it by years played, so exposure to the sport, we see an increased risk of neurodegenerative disease mortality for 2+ years of play, but a protective effect associated with participation for respiratory and digestive disease mortality in particular, but again, no clear sort of dose response effect apparent. And we see similar results as the years played for matches played in terms of the sort of effects that we're seeing and the outcomes. And again, no clear dose response effect. So just to conclude what we do see an increased risk of neurodegenerative disease diagnosis and mortality for high-level rugby players. And this does seem to be an increased risk observed specifically with backline playing positions, as well as greater exposure to first-class level rugby, though, as I mentioned, there doesn't seem to be a clear dose-response effect in terms of how much exposure you're getting. As I mentioned before, the results around playing position have been limited and mixed with the literature. Players in the forward positions are generally more exposed to contact events, but backline players seem to have a greater risk of injury. So it could be the nature perhaps of the injury, so the speed maybe, or the direction of the tackles that backline players are exposed to that could be having some sort of influence on the risk. We do see a reduced risk of some causes of death, so an increased risk of mortality by neurodegenerative disease, but reduced risk in relation to metabolic and respiratory disease-related deaths in particular. And I think it highlights that it's important to consider both the risks and benefits of the sport, but given the increased risk of neurodegenerative disease diagnosis and mortality, efforts should really continue to reduce the risk of head trauma. And again, as we don't know the exact mechanism underlying the association between risk and head trauma, research efforts do need to continue to understand ways to mitigate the risk of neurodegenerative disease associated with participation in contact sport. And then just a few caveats, of course, with the data that we have. It's great. I think a lot of the research so far has used a lot of cross-sectional and opt-in kind of designs with limited follow-up if there is a longitudinal study. So we were able to do that, have a longitudinal follow-up, have larger numbers, but working with administrative data, there is the risk of undercounting cases because we are relying on service use data and there's no primary care data there where we may get a lot more cases identified. And of course, we have no direct measures of exposure to rugby-related factors, so no actual measures of how many head impacts they've gotten during their careers to actually look at, whether that's some sort of underlying mechanism. And then there's also been a lot of change to the sport. So we looked at players that were active from 1950 to 2000. There's obviously been a lot of change to the sport since then, particularly with the shift to professionalism, which was in 1996. And that was towards the end of, obviously, our window. So there's been changes to the build of the players, the nature of the impacts, the ethnic composition of players as well. And that may affect the generalized value of the findings, as well as the fact that we just focused on males and not females. So we don't know how what the results would mean for female players as well. And then just to quickly finish up, I just want to thank the wider Kumanu Tāngata team, especially Barry, Chow, who've done a lot of the analyses, Fran, who's my PhD student who worked on the neurodegenerative disease outcomes, and Ken from New Zealand Rugby, who has been involved in writing the papers as well. World Rugby and New Zealand Rugby Foundation for funding the work, Stats New Zealand, of course, for access to the IDI, and the PPI at the University of Auckland for access to their data lab. Should I answer the question that's in the chat? There's one that's just popped up. How was the general population selected? This was males who were born between 1920 to, I think it was 1984, something like that. So the same years that the players were born within. And this was just taken from the personal details table in the IDI. Sorry. Yeah. So included all who were essentially ever resident in New Zealand during the sort of time periods that we were interested in.
I wonder, it's probably quite difficult with how the data sets put together and probably quite painstaking to do, but if you could work out a way to include an indicator for players that wear headgear most of the time or some of the time, because you can really get a sense of protective, it's quite a common thing for forwards to wear headgear. But
interesting.
Tricky thing to do, but
there isn't really an indicator in the data set.
It'd be something you have to do quite manually. But.
Yeah, exactly, which I don't know if they recorded that. They probably didn't, I think, in the register. Yeah, you'd have to go back and look at a lot of, Sorry, was the...
Can you look at the risk between the rugby players and the general population by different ethnic groups? Because, as neurodegenerative disease, the incident rate or mortality rate is much different between different ethnic groups.
Yeah. So the question was around looking at the risk of neurodegenerative disease between players in the population and, I guess, stratified by different ethnic groups, right? We theoretically could. We would probably only have the numbers, I think, for New Zealand, European, and Maori. I don't know how many Pacific players we had at that point, because I think it's more recently that we do have a lot of Pacific players now, and I think that's part of the kind of caveat there that I mentioned is this shift in the distribution, the ethnic distribution of the players. Oh yeah. So it does get fairly small for players basically beyond European Māori. I think that's part of the it would be useful to be able to do, I think.
Yeah, because especially this summer disease.
Yeah.
This Māori and European
Yeah.
disease, then
Yeah, it is something we could, I think, consider at least doing for European and Māori. Yeah.
So you, when they look at something that is diagnosed with neurodegenerative disease, do you not look at concussion or head injury data?
I don't think we'd have good measures of that. We potentially could look at it through hospitalizations for concussion and head injury, but and look at clinical codes that way, but not necessarily during the sport. So it wouldn't be kind of reflective of during their career unless it's so bad that they had to go to hospital. Yeah.
And would it not be in ACC, or would it not?
When does
It happens
ACC?
at work.
I think part of the issue is when
Oh,
ACC
yeah.
starts.
74 in fact.
Does it?
Yeah.
ACC started in 1970.
It did, but the data
That and the
used
IDI.
Yeah.
Would have been
Yeah.
much later when they actually started.
Yeah.
Classification.
Yeah, true.
There's very little before 94, and actually even after that it gets really good. So one of the issues is a lot of the rugby players that we've got, lots happening to them before we have any health records about them, essentially.
Yeah.
It's just a known unknown, unfortunately.
Yeah.
You're right. I mean, there's and the Pacific thing is a similar thing. So we're capturing a population before there were a large proportion of Pacific players in the rugby playing population.
Yeah.
So it isn't capturing the rugby population now on the one hand, but if we had the rugby population now, we wouldn't follow them for any length of time and look at diseases anyway. So you can't have it every way kind of thing.
Yeah.
Are there any factors that you wanted to control for but you weren't able to? I was thinking about alcohol, for example.
Yes.
I was going to ask
Yes.
about that because the fact that forwards are much less likely to die of alcohol substance use compared to backs might indicate that backs are more likely to have high levels of alcohol and substance use. Maybe that's what there's no way you could.
Yeah. We wanted to initially also, because with the rugby register, we had information on, for example, referees, and we were trying to, we were hoping to have a comparison group with the referees that were kind of exposed to the culture of the sport potentially, but not the physicality of it. But unfortunately, that was a very biased sample because they were identified through mortality records, so we couldn't really do it. That is something we have thought about as well around substance use and alcohol intake, because I think there is, some, the culture particularly, I think in the 90s was a little bit more partying with players and yeah, so that could be something as well, not just the sport. And again, I think that's also something that is unknown in the literature around, with CTE and neurodegenerative disease. Is it just head impacts, or is it other things that are affecting the brain as well? Yeah.
That's an interesting one I was thinking of. Once the professional, they finish their professional career, but some of them still go down and play at the lower levels
Yes.
of rugby and go into other sports.
Yeah.
So it's interesting what might be the effect from there on neurodegenerative later.
Yeah. At a lower level. Yeah.
Yeah, just in terms of, obviously they are doing sports and the general population aren't doing the same level of physical exercise, so it could seem like a bit of a difference in terms of the protective factor. Was there any thoughts about wanting to get a different sport cohort to compare against?
Yes, I think there is discussions about potentially getting a cricket cohort in there. So that would be great in terms to be able to compare like elite level athletes or high level athletes, I should say, but one that's not really exposed to the head impacts like rugby. Yeah.
Can I jump in there?
Yes.
So there's talk which I'm dubious of its value of introducing the cricket cohort in there. I'm dubious of its value because ethnically and socioeconomically, cricket players are quite a lot different from rugby players. But there is interesting literature in the States that show, the predictive effect of playing sport generally, but you get a predictive, comparing baseball players and football players, baseball players don't have the increased risk of the neurodegenerative diseases, whereas the American football players do. So I think there is value in that sort of approach. I just think with the inability to control for long ago socioeconomic status and the fact that most cricket players are white and many rugby players aren't, I think for this particular question, I don't think it would work. That's my view, but there's talk of doing. There might be other reasons to have cricket players look at cricket players, but I don't think it creates a fair comparison. Is my view.
Thank you.